My name is Jessica Waterworth and I'm an exercise physiologist. And just to start with, I'd like to acknowledge the Gadigal people of the Eora Nation, the elders past and present, and thank you to Arnie Ann for her welcome to country this morning. So I've just been asked to speak today, so I thought I'd give a little presentation on just my position as an allied health practitioner, what I do, how my position's kind of set up, and just a couple of stories and what it's like being on the ground. So as an exercise physiologist, my job is to prescribe exercise as a form of treatment. So I work with people for different reasons, and the majority of my referrals for exercise rehabilitation come because of an injury or pre or post-surgery rehab, or for some lifestyle modification, so for people that really need to change their overall health, and people that are suffering from chronic illnesses and conditions. So I'm employed through South Western Sydney Local Health District with funding from the Rural Doctors Network. I'm a part of the Close the Gap health promotion team, and my position has been set up across 2 different locations. So I'm set up at Poojari Aboriginal Community Health Centre in Miller and Thurlwall Aboriginal Corporation in Ayres. Both locations provide services to the Aboriginal population, however, how they're set up and how they're run is a little bit different. So I'll start with Poojari. Poojari is a community health centre in Miller, and it's about 40 kilometres southwest of the CBD. The community centre runs as part of the Aboriginal community, Aboriginal chronic care program, and the program runs from referrals from GPs, specialists, self-referral, hospital discharges for 48-hour follow-up. And the program is for people who suffer from chronic conditions and illnesses in the Aboriginal population. So the ACCP program, which I'll just refer to it instead of the Aboriginal Chronic Care Program, has care coordinators and Aboriginal health workers mostly who have first contact with a client. So the program also has full-time nursing staff, dietitians and a social worker. So how I fit into the ACC program is as a visiting service. So like myself, there's a number of different specialists who visit the community centre and run a clinic either once a week, once a fortnight, once a month, or on a rotating kind of roster. So the clinic is a 6-room facility, but we make it work with how we rotate and the different days that everybody visits on. So I have a room 1 day a week to see the ACCP clients. So once I'm referred a patient, I'll contact them and organise an assessment or a home visit. So 75% of the time I see a patient in their home, and I'm lucky enough to have access to the department's cars to use to see patients in their homes. So it's important to see how a patient lives, how they mobilise around their home, and it allows me to provide them with a home-based exercise program that they're able to do in their home with what they have in their environment. And it's also important to meet the clients' families to see who's going to encourage them and who's going to be their social support along the way. Because Poojari is an LHD facility, it means our computer software and email system is all the same. So that's a bit of an ease of access to be able to get onto other health professionals and be able to talk to people that might have seen the patient in the past before. So the Aboriginal health workers are our biggest asset at Poojari. They have a history of the area, they know the clients, they're readily available to go on home visits, and as a non-Aboriginal woman, the Aboriginal health workers have been my biggest asset, and they run alongside me during home visits. They allow the clients to feel comfortable, and they also have confidence in my ability, which supports me with building rapport with the clients. So they have the clients have faith in the guidance that they receive from their Aboriginal health workers, and that's the biggest thing. So at Poojari, the majority of my clients are shared with the dietitian services as we work as a multidisciplinary team, and it's often that a patient is provided with multiple services at once. So having both an EP and a dietitian and an Aboriginal health worker on the same home visit may seem a little overwhelming, but once you get to know the people and you build that rapport, it's quite good to have that kind of whole lifestyle change and all that advice for how they can change their life all at once. Because of my position at Poojari, I've been lucky enough to be involved in running an exercise group in partnership with the PHN. So it's very similar to the Auntie Jean's program, how that's set up. So the group runs once a week and involves me attending the gym and helping clients with their exercises. So the program itself provides each of our clients with a gym membership at our local gym, the Wendon Centre, and they're able to attend the group on a Friday and then independently throughout the week. The group program is great to refer clients to, and it can also be seen as a little bit of a next step for some clients who never thought that getting into a gym would be something that's appropriate for them. A lot of clients see exercise as bodybuilding and weightlifting and sweaty, and they never think as a 60-year-old fragile woman that that would be something that's appropriate for them. So the exercise group is really great to break down that barrier. For the past 2 years, I've also had the chance to attend the annual sports day for the elders, known as the Elders Olympics, and we have coordinated a team from my exercise group. So my first year I went, our team won, which was fantastic. But then it set the standard really high, and this year we came second, which was very upsetting. But it was still a great day for the elders. I have a little client story which had stuck out to me, and it was a client who was referred to me, a woman in her 50s, her late 50s, and she'd broken her femur from a massive fall. So she'd basically broken her leg, she'd had surgery, and she was at the end of her treatment and she didn't know what to do next. And she had been guided by the hospital to attend physio, but was all too overwhelming for her, and she didn't know how to get there or what to do, so she just gave up. But she had a really good relationship with our Aboriginal health workers, and they kept encouraging her, and she ended up accepting to see me in the clinic, and I gave her a really simple program to start with, and she did it at home, and then she came back, and then she decided she wanted to try the gym program. Then she tried the gym program, and now she comes every single week to the gym. So she attends the group on a weekly basis. She was a very quiet person with low confidence, and she would bring her brother to every single appointment. And now the both of them come every single week without fail to the exercise group. So that's something that really shows how the Aboriginal health workers have really helped me with making relationships within the community. So one of the greatest things I love to hear from our Aboriginal health workers, Wendy, who will be here tomorrow, she always says to people after she's done their observations in the clinic, if they've had a really good blood pressure or a good blood glucose reading, she'll say, "Oh, bloody get out of here, you're too healthy for me," and she kicks them out the door. And I think they actually love to hear that as well, because that's something that knows that they're taking control of their health. So the other location I work at is Thurlwall, and that's an AMS. It's located in Ayres, which is about 55 kilometres on the kind of outer skirts of Southwest, and it's a very large and recently renovated facility. So there's multiple buildings on premise. There's a medical building, which has full-time GPs, podiatry, Aboriginal health workers, and all allied health services and specialist services. So generally anything that you would need to refer to is on site in the building. So the building has over 30 rooms, and it's kind of a big square with a courtyard in the middle. So there's a social emotional building as well, which has mental health workers, drug and alcohol workers, social workers, community workers, and then there's a third building for dental, which is really accessed as well. So I do a clinic 1 day a week at Thurlwall as a visiting service, and now Thurlwall is a bit of a larger scale, and even 2 years later I'm still meeting people who work there that I have never seen before. So there's multiple GPs that are on staff Monday to Friday, so you might have 3 to 4 GPs that are always there every day, Monday to Friday, which is great, and it means that there's such a large database for clients as well. So most of my referrals at Thurlwall come through the GPs, the dietitians, and the orthopaedic surgeon who does a monthly outreach clinic. Having a partnership with the AMS means an ease of access to the community and the clients that are in need. So 100% of my clients are seen on site, and they're booked through the reception. So Thurlwall also provides a transport service for eligible elders, which is really helpful in getting people to and from their appointments, because that's one of the biggest barriers that we see. So with all staff being on site, it means I can easily talk to a GP, or I can go over to somebody else's room and liaise with them about a patient to provide the best patient care. The major success of the development of my clinic at Thurlwall is the referrals I'm seeing now. So I started my position in October in 2016, and I was lucky to have one person booked into that clinic. And now I have periods where I'm booked out 3 or 4 weeks in advance, and I have 7 to 10 people in each clinic. So that's been really great. And it showed me that the referrals and getting to know all the doctors and other allied health practitioners is working. Thurlwall has a huge range of programs and community services. So they have on-site cooking groups, sewing groups, dancing groups, parenting groups, hydrotherapy, mental health, you get the point. I've been able to start an exercise group which meets in their community hall, and using a variety of different portable equipment. The group is small and intimate, but it runs as a low-intensity beginners exercise class, and it's a good referral for my clients who I want to monitor on a regular basis, and they need that supervised support. So being known at Thurlwall has allowed me to assist in the implementation of an Aboriginal Go for Fun program, which is a great kids program which incorporates nutrition advice and physical activity games, and it's fun for the children and their families, and it teaches them a healthy lifestyle from a young age with the child and their parents there. Thurlwall being a much larger place means it was a lot harder to establish myself. I was constantly walking the corridors, I was knocking on people's doors, I was having a chat with any other staff member who was free, and there's often a 6-month rotation of GPs. So every 6 months some leave and some new ones come in, which means that every 6 months you don't really know all the new staff members. So a story that sticks out to me from Thurlwall is I had a referral for a male in his 60s who had suffered post-traumatic stress. He had had hypertension and he was a very heavy smoker. So previous to his PTSD, he'd been a company manager, and after the PTSD event, he'd struggled to leave the house. He wasn't able to catch a bus more than 3 stops at a time. He wasn't able to stay in a car for an extended period of time. He stopped driving himself and was seeing a psychologist and had a very close relationship with a GP. So he was referred to me for weight management, as being at home all the time meant that he was putting on quite a bit of weight and his lifestyle had fallen out the window a bit. So the GP decided that he was ready to make a change. So from then to now, I originally saw him as a one-on-one session in the clinic, and after a couple of different sessions, I convinced him to come to my exercise group I was starting, and he was one of the original members of the group. So now, this time later, he comes every week without fail. He's more social, he's become friends with someone else in the group, and they come together every week now. He's lost 10 kilos. He told me on Tuesday that he'd quit smoking for 2 years and 12 days, and he was very proud of himself. And he'd taken his health into his own hands. He actually sits down in reception now and says, "Does anyone know Jessica? Who's going to come to her exercise group? You all need to come to exercise. You all need to change your lifestyle." So he's one of my biggest advocates now, so that's great. And he has faced some tough times, so he's just awaiting shoulder surgery at the moment, but that doesn't stop him. He still comes and says, "All right, my legs hurt last week, but I'm going to do it again anyway." So that's been really great. For me, the reason that both sites work so well in the delivery of EP treatment is because it's integrated with other health practitioners. It's a holistic approach to care, and quite often multiple practitioners are working with a patient at once. So if I'm referred a patient, I can liaise with their care coordinator, their GP, their Aboriginal health worker about the patient. And the access to clients is important as my position has been set up at 2 major facilities. So I'm right in the heart of where the community is. The patients can access the services and have like a one-stop shop when they come. They can access whoever they want. Another reason the setup of my position works is because it's affordable. So the service is free and it requires no payment from the patient. So this has been really important as it allows patients to access the service without having to think twice about money. And thirdly, the Aboriginal health workers. So because of them, I've been able to establish myself with their support. They know the community, they know the area, and they always give a heads up about a patient, and the patients know them, which is important. So just shy of 2 years ago, I started this position. I won't lie, it wasn't an easy position to step into, but I quickly made myself familiar with 2 locations with different employees, different referral systems, and unfortunately 2 different software systems as well for the computer, which was probably the hardest thing. I get to see the clients, I get to know the staff now, and I feel like I'm part of a holistic team providing outreach to the communities at both locations, and this allows me to prescribe exercise as treatment.
I've had the pleasure of working with the Walgett Aboriginal Medical Service since September 2014, where I started as a chronic disease manager, and that is still my position now, but I'm acting clinic practice manager while we're in a recruiting phase. In chronic disease, we have multiple programs. We obviously have Healthy for Life, which is responsible for the annual health checks for Aboriginal people. We have an outreach program to Pilliga and Gadooga. There's also a Brewarrina program, which some of my staff visit. We have drug and alcohol workers, eye health, Aboriginal health worker, e-health program with an audiometrist, an Aboriginal health worker, Aboriginal family health worker. I could go on and on. Thanks to RDN, we have a range of specialists and allied health who come and provide services, and I have had many a person that have been visiting or who live out on the stations coming in to see specialists who comment that, you know, I get the best health care here than I ever got living in the city, because it is accessible, it's all bulk billed, and our specialists and allied health people are terrific. Very culturally appropriate, and we are very, very lucky to have them. And some of them have been coming for a long, long time also, such as Luke Buckman here, who's our podiatrist, been coming for 10 years plus, probably, close to that. I feel very, very, very lucky to be working within the field of chronic disease. Everybody knows chronic disease is what it's all about now. And most areas of work come under that banner. It doesn't matter whether you're looking at dentistry or you're looking at exercise physiology, even antenatal. Everything is geared towards trying to prevent, identify, manage, treat chronic disease. I want to ask a question, and you don't have to answer if you don't want to, but who snores? We've got a few snorers? Oh, good. One of the most exciting things that I've come across in my work is, thanks to the IDN, they have funded for 10 CPAP machines, a range of accessories, and 4 days training for an RN down with the Adelaide Sleep Health Centre. I wasn't the RN that was going to be going. The one who was going got pregnant. So I ended up doing this training, coming back and running a nurse-led sleep apnea program, which was a pilot project developed by the Adelaide Sleep Health Centre. So it's in consultation with GPs and with the respiratory physician. But nurse-led program can see clients who are not overly complex, but it is fantastic for people. It saves them travelling 3 hours to Dubbo or 4 hours to Tamworth for an overnight sleep study. So clients come in and we use a device called an apnea link. I'm not sure if people have seen one of those, but it's a little device that straps on the body, and they have an oxygen nasal cannula on and oximetry, and you send them off, show them how to use, they go home, they sleep with that on, they can bring it back the next day, plug it into some software, and it spits out a report which is an indicator as to whether people have obstructive sleep apnea or not. It is only obstructive sleep apnea that we're looking at. What this program has been able to do is not only pick up people with severe sleep apnea, but also to indicate that that is not the reason for people snoring, and they have then been referred on to ENTs or whoever to look at more mechanical reasons why people might be snoring a lot. One of the things we look for with sleep apnea is excessive daytime sleepiness, and everybody undergoes doing the simple Epworth sleepiness score survey at the beginning and during their time in the program, which is out of 24. So people it's obviously a subjective rating of when they're most likely, how sleepy they are and when they're most likely to get drowsy and all that. And then if their reports come out that indicates that they have got moderate to severe sleep apnea, they can have a trial of APAP, automatic continuous airway pressure, using CPAP machine that's set as APAP. I know I'm all talking to you, all know what I'm talking about, but I'm just explaining myself. So people go home with this machine if they wish, and they use it for 3 nights, minimum 4 hours a night, come back, plug it in, and it again tells us whether that has been of assistance in reducing their level of sleep disorder. Now, what I would like to say, I mean, I could hear Jessica's passion for her work and the excitement when you know, you can see clients are really getting something wonderful out of what you're doing. And I've got a case that I'm just going to briefly go through just to give you a picture of how glorious this program is. A gentleman who's in his 50s, an Aboriginal man, came in with his wife, and his wife dragged him in and sat him down. And before I'd even finished sort of my explanation of what I do and all that stuff, he was asleep. And I looked at his wife and she goes, he always does this. Anyway, a bit of prodding and trying to get his attention so I could, you know, hope that he was hearing what I was trying to explain. And he kept his eyes shut and he just grunted at me. Anyway, so I talked to his wife and she could answer all the questions about his daytime sleepiness and his nighttime snoring. And he went for a trial of the apnea APAP. But obviously you've got to fit masks. You've got to try and find a mask that's going to work for people, even for just the trials. So I've got a mask that I thought would fit and fitted on him. I was explaining this to him. His eyes were shut at this time. He's half asleep. And so got the mask on, turned the machine on, and his eyes opened. And then they shut. And he didn't say anything. And I looked at his wife and I said, "Is that all right?" He goes, Anyway, she was prodding him and asking me, "What's that like?" He goes, "Don't talk to me." He loved it. He didn't want to take it off. I couldn't get him out of my office. He just wanted to relax, feeling that air coming. I've never seen anybody take to it so well. Anyway, he went off with it. And in a week, I had him back in and he said, "It's just amazing. I just feel so much better," and he was more awake. Over the next few weeks, and the next couple of months, he was staying awake during the day. He had started to take himself for walks. He'd previously only travelled in a car or on a mobility scooter. He had a background of type 2 diabetes, early renal failure, hypertension, morbid obesity. He was actually too complex for a nurse-led program. However, he had refused to go to Dubbo or to Tamworth. He just wasn't going to do it. He was too tired. So he's complex. Yes, I broke the rules, but I thought, well, what harm can it do? And in fact, he has got up, he's moving, he's happier. I haven't seen him on his mobility scooter for quite some time. And then, as per chance, what happened was we ended up getting the Too Deadly for Diabetes program. I'm not sure if you've heard about that, but it's run by an Aboriginal man called Ray Kelly. And it's a very clear, structured program for weight loss. And then it moves on to exercise as well, but it's primarily weight loss because there is evidence that shows if you lose weight, even if it's 5 kilos or whatever, a lot of people actually find their medical conditions start to improve. So he did this. I couldn't even believe that he put his hand up for it, but he started doing that, he and his wife. In the first week, he lost 4 kilos, and he was wrapped, absolutely wrapped. Now, he would never have had the motivation to do that before because he couldn't stay awake to hear what anything was about. So I saw that as just a wonderful flow-on effect from a man who still has a lot of complex medical problems, but he's getting some quality of life, and that's what it's all about, I think. So he's continuing on. He's now lost 15 kilos, I believe, and he's a different man. So I like to think that the obstructive sleep apnea diagnosis and use of CPAP really contributed to that. So I haven't really got a lot more to say, but I'm very happy to participate in question and answer.
Okay, good afternoon, everyone. First of all, I would like to acknowledge the traditional owner of this land, and the present and the past members of this of the community. And thanks to the organizer, and I acknowledge our college, Royal Association College of Physicians, which the PowerPoint presentation I'm sharing with. Our college has developed a framework, basically for the medical specialist access framework. So why the college was interested to develop that framework? We all know that there is fragmentation in the medical service, there is ad hoc duplication, and particularly for the Aboriginal community, indigenous people, there are high morbidity and mortality. With the fragmented approach, the problems was compounding day by day. So to address all those sort of stuff, college actually convened a roundtable discussion back in 2014, and to develop a framework which can be guide not only for the Aboriginal community control health services, but also for any organizations, even the mainstream health services across any regions in Australia. So from that college, this is the committee, ATSIC committee, Aboriginal and Torres Strait Islander Health Committee. I am one of the members in that committee, and Dr. Tamara McKean, she is in South Australia, she is the chair. So we all contributed to develop this model. We all know that about the access inequity in the health service distribution. So the Aboriginal health service, Aboriginal and Torres Strait Islander people, they actually see specialists about 40% less than the non-Indigenous people. And if you look at the difference between access to GP or allied health service versus access to specialist services are much less than GPs or allied health services. So basically the college in that roundtable discussion developed that a consensus statement, and the statement actually strategically fit with that Aboriginal and Community Control Health Service Plan 2013-23 and the implementation plan. So what those plans actually talk about, these all talk about the coordinated care, integrated care in a culturally appropriate service, reducing the inequity. So basically one of the plan strategy was guidance on the principles that inform equitable access to specialist medical care. And our college actually developed a national framework with other stakeholders. So that is where from this framework actually has been originated. So this framework, as I told before, it is not only for Aboriginal community, Aboriginal health services, because not all Aboriginal people live in communities. They also, not only they access only Aboriginal services, it is also the fact that not everywhere Aboriginal services are present. So it is also applicable to the mainstream services for any people, including the Indigenous people as well. So this framework actually consists of 3 parts: the principles, roles and responsibilities, and the enablers. And then have some case studies. I can discuss some of the case studies, so that will clarify how this framework has helped to address the inequities in health service delivery. So the principles are basically like Indigenous leadership with the self-determination, with the community control health service, their boards, community health committees. They decide what their health problems should be prioritized, how they can participate actively. It is not only the passive recipient. That has been the problem in the long time. Passive recipient in any health service or any service doesn't help unless and until the people participate actively. We all talk about we live in a multicultural society and there are diversity of people, their opinion, choice, so the services must be culturally appropriate. Person-centered and family-centered, it doesn't need any discussion because a long time, a lot of specialized services have focused on the system or on the organ, the hepatology, on the liver, but liver does not work in isolation. So it is the whole of person approach, whole of family approach, whole of community-centered approach. So that sort of issues have been addressed in this framework. Flexibility always, because in the rigid model, it doesn't work. So the services must be flexible, must be accommodated according to the service, according to the people's need and their wishes. And also, it must be sustainable. It is not a project work. The project finishes. That has been a long time problem in many service areas. The project work, project finishes in 2 years' time, everything finished. It is not. Services must be sustainable. There must be economic way out how that services can be sustainable for the future. And then and only then you can make real improvement. Otherwise, it is very hard to make the sustainable improvement on an ongoing basis. Integration and continuity of care, that doesn't need much discussion because that is the way, only way to go is the integration or continuity of care or care coordination model. I was the inaugural medical director of Sunrise Health Service. Have you heard, any one of you have heard Sunrise Health Service in Catherine, Northern Territory? Okay. So I was the inaugural medical director of the health service back in 2003. So when I was employed, there were only 4 people. And I left after 5 years, 8 months, there were 120 people. And in that meantime, with the doctors, with the healthcare workers, with that nursing staff, with the policymakers, and with the different stakeholders, we developed care coordination model. We assigned care coordinator for those every chronic disease patients, and we implemented the chronic disease care plan with the review of the plan and with the continuity of the care model. And Sunrise really performed well. I can talk about back in 2007 data, when Sunrise data was better than the average national level data for diabetes control and other chronic disease control, particularly for the primary healthcare KPIs, when you compare with the KPIs with the other health services. And the quality and accountability, of course, the service must meet the quality and safety standards of the government of the Australian or the GP services or the Australian Commission on Health and Safety. So why the principle-based framework? Principle-based framework is basically a strength-based approach, not the deficient-based approach. So what the people can do rather than what we can't do. So that is the whole idea. And also, as I mentioned before, this model can work in any urban area, metropolitan area, rural area, community sector, primary care level, or in the interface between the specialist, primary, secondary, and tertiary care level. There have been a few case studies. You can go to the websites, say particularly for Catherine area, a physician, general physician, Dr. Simon Quilty, he goes to the clinics. So Catherine actually East and Catherine West, there are 2 Aboriginal community control health services. He mainly goes to Catherine West, and he is the main sort of medical person for the patients, and then he, as a general physician, contact the subspecialist, say diabetologist or rheumatologist, and maintain the continuity of the care. And this model has been very, very successful. There are other models in the North Queensland from the Cairns doctor, Dr. Asim Sinha. There are other models, and these models are in the website. I will give the website address later on. So, as told, it is not only for the doctors to work or not only for the community controlled health services to use, it is for any health services, because that there is a guide, there is a framework. So with the continuity of care, with the person-centered, family and community-oriented to reduce the inequity. So it can be relevant to any government, non-government organizations, primary health network, the health districts, and so on. So these are the online. We have some brochures and booklets. You can use that one. So that talks about the framework in details. So how you can use that one for the benefits of the people. And that framework is the first part. So we are looking for this, developing the second version. So Beth, is the second version due in December, is that right? So the second version, so we are asking feedback as well. So feel free to give feedback, go to that website, read the framework details, and we are happy to get the feedback so that it is effective for the disadvantaged people, for any people who have problems with the inequity. So thank you. I'm happy to get questions and happy to share my experience. Thank you.
I'll start the ball rolling. So, and this is for, well, it's for everybody really, but certainly would involve Jessica. And the question is, there has been discussion in the medical literature about doctors prescribing exercise as they might prescribe, say, a pill. How do you think prescriptions for exercise might look, and what are the cautions that should be observed?
I'll take this. Hello? Oh. Hello? Okay. So I suppose in terms of exercise prescription from doctors, for one, I think that it's a good step. I think it's good that a lot of GPs now that I work with especially are moving towards more preventative health rather than just giving out another prescription for clients. I think that it's hard because you've got to encourage a patient to change their lifestyle with exercise rather than just a pill, because you know, an hour of exercise a day seems a lot harder than maybe a tablet that they can just pop with the rest of them in the morning. So I was actually speaking to a doctor at Thurlwall about this, and she said, I prescribe exercise all the time and I always tell my patients that they should exercise, but they just don't listen. Maybe I need to start actually printing it out on the prescription piece of paper so they can take it home and know that that's their medication instead. So I think that in terms of exercise prescription from a GP, that there's definitely things that a GP could prescribe exercise-wise. So something simple like you're diabetic or you've got high blood pressure, you've got high cholesterol, you know, doing a 15-minute to 30-minute walk a day could help you with these kind of things. That's something that I would say is quite an easy thing for a GP, but in terms of having some more of a specialised sort of prescription, that's when it would generally need to be referred on to an EP for that kind of thing, yeah.
Dr. Feld, yes?
I think prescription for exercise, I think I can remember I was working back in north of Western Australia back in 2000, and at that time Victoria introduced, I guess, the first one, green prescription. So I used to promote amongst the GPs the green prescription. Now, Jessica is a specialist in physiotherapy, so that sort of specialized advice is important, particularly for, say, someone has knee surgery or the back surgery or after post-operative rehabilitation. But we all can take everyday moderate level of physical activity. Physical inactivity contributes about 6% of the total disease burden in Australia. So we all should promote, everyone, that a moderate level of physical activity. Moderate level means, I think there is a definition, the US the Center of Health, they define what is the moderate level of activities. That does not need medical assessment. So that level of exercise people can do. The moderate level of activity is walking at a speed where you can talk comfortably but not sing. So if you walk and you can't talk comfortably, that means you are puffed out. So that is not the recommendation without medical assessment. On the other hand, if you walk too slow, then you can sing and walk, but that is also not good for health. But probably any level of activities is good for the mental health as well. So moderate level of activity, most of the days of the week, at least 30 minutes a day is always recommended.
Just a very general question. What role can the physician play, and anybody can answer this one, in the avoidance of unnecessary hospital admissions?
I think we have to look at why it is happening. Say sleep apnea, why it is happening? Is overweight or COPD, what are the other problems? So we need to look at the cause of the causes. And only then we will be able to make a sustainable solution. So why the repetition, why the unnecessary, unplanned admission? Because the main primary health problems has not been managed well. So there comes the coordinated care or integrated care model. So in Catherine, what we implemented, we had a dedicated chronic disease day clinic. Before that, we took all the clinics from the NT governments, and then we got the funding and we got the responsibility with the community members, with the community health boards, with the board's aspiration that we need proper management of the chronic diseases. So we then implemented, say, Tuesday is the chronic disease day in that community. So the patient comes, firstly assessed by the Aboriginal health worker, then having a chronic disease from the health records, or he or she suspects something, then goes to the nursing staff, then the medical doctor, because we could not doctor every clinic every day, because some of the communities have, say, population 200 or 700 to 1,000. So the 1,000 community, that is the Nukar community. Many of you might have heard the name of Nukar. About 1,200 people live there. So in that dedicated day, we used to do the care plan, and that generated good amount of money from the MBS item. So if a diabetic patient has the chronic disease care plan with the continuity of care, with chronic disease self-management, that is very, very important, because the patient empowerment and responsibility is in place, then a lot of unnecessary admissions and availability of the services, not the physical one-to-one physical presence, but also to the telephone or telehealth, can reduce that sort of unnecessary admissions in the hospital.
Thank you. Acknowledging that there is a tension between the fostering of patient dependency on healthcare systems versus the preservation of patient autonomy and empowerment. And I'm just wondering how people think this tension can be addressed, because it is a real issue and potentially a real problem for people. So what do you do in your practice to manage that balance and provide that care, but also support and maintain autonomy and empowerment? What do we all do?
That's something that we have to remember all the time when we're planning our programs. There's often a pull for us to provide outreach to areas that are very near the town, and because that had been done previously, but most people do have ways, and we also provide transport for clients to get in to see their GP or whatever. My concern is if we do go out and provide our services to a place that is 3 kilometres out of town and do that on a regular basis, I think we're taking away people's, empowerment opportunities for actually getting themselves into appointments. I struggle with the not going too mainstream, and I have some wonderful Aboriginal health workers who pull me back if I am, and they say, hey, we need to get back to the riverbank sometimes, and that might mean going out. This is where I have this dilemma, going out there and sitting down and, having a yarn and providing services out there, out of the clinical environment. It's a juggle, because I don't want people to have their independence removed in the guise of doing things in a more culturally appropriate way, when we might not always be able to do that, and then we'll be like we're taking a service away from them. So my thing is, yes, we'll do it, but we'll do it as a once-off, or we'll do it 3 times once a month over 3 months, but not to promise anything long-term, because I still want people to be able to, get their appointment and get in and see who they've got to see. Some people, some specialists in allied health are not going to go out in the riverbank, so it's hard, because sometimes it's the right thing to do, to go out in the riverbank.
Yeah. There is some growing evidence of the value of the placebo effect concerning the patient's sense of well-being, as well as measurable improvements in health. Is this something we can address as health workers? And is this an issue for consideration in terms of face-to-face compared with telehealth consultations? Is there a therapeutic value in a face-to-face consultation leading to measurable improvements in health that we need to better understand? Does anyone want to respond to that one?
I can talk about my view. Yes, at the end of the day, how you feel. Different people have different feelings. Sometimes you don't have control outside what is happening, but definitely you have control what is happening within you. I think that makes a lot of difference. So that is related to whether you are stressed or not stressed, you are happy inside. So when you are not happy, when you are stressed, our system generates cortisol. Cortisol leads to high blood pressure, leads to cellular damage. When you feel good, the feeling good hormones, sort of dopamine, endorphin, oxytocin, that sort of serotonin, that comes from our brain in our system. So you feel more good. Then you are more recipient. So there has been different studies. So you can feel good through sort of mindfulness training or breathing exercise, and at that level you are more receptive to the things you want to learn, you want to listen, what you want to do. So I would say definitely feeling good leads to better health and well-being, of course. And the health and well-being survey in Australia measures about how the people rate their health. It is not on the measures of I have diabetes, blood sugar is less than 7 point, that HbA1c level. It is not like that, how you feel your health. Now on the issue of face-to-face physical presence or remote telehealth, you mentioned telehealth?
Yeah.
Telehealth, I think we have to accept that it is not always present every time physical presence. So telehealth, you can observe the body language. Body language is one of the main things. Different things, same things can be told in different way through body language. I think to those people who analyze the power of the words and body language, I think the words have only 40% values. Body language has very high values as well. So my view would be, let's be practical, let's be realistic. It is not possible to get health professionals every time face-to-face. Where it is not possible, then you go to the next level, telehealth or teleconference, that sort of way. So that is my view. Thank you.
Thank you.
Okay, so we're talking telehealth. It goes without any technical hitches. Does anybody have that happen? Let's say we have no hitches and so everything works perfectly. I would say a lot depends on the relationship. If you have the time to develop a relationship with the person there, the professional that you're seeing via telehealth, it also depends on who is in the room with you and how comfortable you feel is the sort of value you walk away from. So I've seen telehealth work extremely well. I could tell, I didn't measure it, but I could see people be really, really satisfied and feel very, very, very happy walking away when technology worked. They had someone in there who they felt supported by, who could explain anything if they didn't understand it, or they already had a good relationship with the person, a professional on the screen. I've seen really bad examples of telehealth when they felt they were being rushed. Being rushed in telehealth is 10 times worse than being rushed face to face. You really do feel like you don't matter. So, you know, in that case, people walked away not feeling great at all and refusing to come back because it didn't feel it was doing any good to them. Well, it actually was doing them some good, but it wasn't making them feel good, and that's what mattered to them. Mm-hmm. So it's not, I don't think there's a placebo effect. I would say no, but the quality of the service, there's so many more variables with telehealth that can affect people's experience of whether they actually feel better or not from it.
We've got to the end of the day very well, and just a moment for me to sum up. But before I do, thank you to the panel for your wonderful contribution. Thank you.